Can you comment on the kind of safety and effectiveness of exercise people who have OA and might have another chronic condition? Is that any different from the information that you presented?
Thank you for the question, Lisa. Well, this is quite a new area, but as of now, there are evidence that exercise is effective also for people only with OA and OA plus up to 4 chronic conditions. And I'm referring to some data which have been recently published on the GLAL database from Denmark, which shows that the pain reduction in an exercise intervention, which lasts from 8 to 12 weeks, it's about 30%. And despite people with comorbidities having higher pain at baseline, the reduction in pain is comparable among all these groups. These are data from non-randomized studies, but they offered a good indication for the effect of exercise being the same also for people living with other chronic conditions.
And would we have any indication about the effect of, or any reason to believe that the effect of these chronic conditions would impact the effect of exercise on joint cartilage?
No, I would say no. What it matters, we know that cartilage is really hard to damage when you exercise. There are also studies on some long run or endurance training or endurance athletes, which shows really that yes, some changes may occur, but then after a short while they go back to the baseline level. So it should be safe also for other people with other chronic conditions.
No, I see you're being very polite there and raising your hand. I do want to point out too, I want to thank particularly Alessio and Mel for attending today, despite the results of the Euro Cup. So no animosity there or anything. That was great that neither of you canceled. So thank you, but go ahead, Mel.
I just wanted to add to Alessio's comment just about the kind of role of comorbidity and whether it kind of moderates the response to exercise, because we looked at comorbidities and we found that there was no differential response. But it was also interesting that when we looked at how comorbidity was measured within the trials, so looking at all the trials, it wasn't necessarily measured at all in all of the trials, which was quite interesting. And also how it was measured was very variable. So how we included it in SEER was we had to do a comorbidity count. So we had to do number of comorbidities. But what we couldn't determine and what we were really interested in was the kind of impact of the comorbidities and the severity of the comorbidities. So I think at the moment how comorbidity is measured is limited and it's inconsistent. So I think that if that's kind of one area that we can do as a community is to kind of more consistently and more thoroughly measure comorbidities, I think it would be really helpful in this important area.
Oh yes, I totally agree.
Yeah, it sounds like, yeah, kind of consistency of measurement is an issue in many areas, and certainly kind of being able to standardize things so that they're more comparable, regardless of, whether we're talking about exercise or I referred to that in terms of EIH, and here we're talking about, simple measurement of comorbidities, and all these things have an impact on how we can interpret things. All right, we have a message here in the chat from Alison Chang, and this is for Mel and Jos. And she says, impressive work in IPD analysis. I'm curious about the moderator graphs. You showed those with higher pain intensity experiences. Higher pain intensity experience more pain reduction. Could this be explained by regression to the mean phenomenon? In OA, pain tends to fluctuate over time. If participants happen to have a pain flare-up pre-intervention, the pain would eventually regress to a less intense level over time, regardless if they receive exercise intervention or not. So any comment on regression to the mean?
So thanks for the question. It's an important consideration, and it's something that somebody else has kind of already highlighted as could that be possible. And I've had that conversation with our statisticians, and that has been accounted for. So no, it's not regression to the mean that would account for that.
Great, thank you. We've also had a couple of questions asking about hand OA. I know that we've mainly focused on hip and knee OA because that's where most of the evidence base lies. And I know that there was, I believe it was a Cochrane review a few years ago now that looked at exercise for hand OA and showed that there was a small effect on pain. But I'm wondering if any of you could maybe speak to that more in terms of exercise and hand OA.
Well, I'm not a hand OA expert, but I do want to make a comment on that. One thing that we didn't address in this project on knee and hip osteoarthritis is systemic inflammation, which I think is also involved in osteoarthritis, also in hand osteoarthritis. And we know that being physically active and doing exercise actually has an anti-inflammatory effect. So I always wonder whether the anti-inflammatory effect of exercise could actually also be one of the reasons why it is effective for hand OA. And knowing that for an optimal effect, you need large muscle groups, I always think that that might be a reason why the effect of exercise on hand OA is so small, because we only have very small muscles being active if we do exercise for hand osteoarthritis. But I think that might be something in the anti-inflammatory effect of exercise that could relate to the effects in hand osteoarthritis that we see.
Yeah, and I would add that I know Alessio had to leave, but in his talk and talking about the effects of potential harmful effects on cartilage, he was focusing on knee OA, and a big, I think, piece behind that there is because of the load and the weight bearing aspect of that joint, and we don't have that in hand OA. So I think that the removal of that would suggest that exercise is just as safe, if not safer, for people with hand OA, and probably the similar parameters around pain intensity and continuing on, I think would apply. All right, we'll turn to you, Dr. Keefe, and I wonder if you can speak to maybe some strategies. We know exercise is effective, and people really struggle to maintain it and be adherent. I wonder if you've looked at some strategies that might help with that as well.
There's been a couple of things that we've been interested in. So one is increasing interaction with those around them. So involving spouses and significant others in the initial exercise program and in the management of the pain, that many of the participants ended up with sort of a buddy system with their spouse or significant other that really played a role in their continuing to use the skills. And of course, many of these spouses are the same age as the patient, and many of them also have their own issues regarding osteoarthritis or other conditions. So I think that's one important strategy. Another very novel strategy that's being tested in several large-scale studies right now is the use of interactive voice response technology. So this is the technology used when you call your bank and you press 5 if you want to check on how much money you have or how many checks you bounced or whatever it might be. But in this case, it's put to use to monitor patients' daily pain ratings, their mood, and also their use of different coping strategies, stressors, things like that. And it turns out that this can generate individualized, tailored messages to patients on a periodic basis. That could be done either by a therapist that works with the patient during the exercise program, or can be done automatically using algorithms. And so there is some evidence, not in the context of exercise studies yet, but there is evidence that this approach results in additional improvements after therapy has stopped. It's actually quite interesting. So we don't get in studies that use this approach the usual, maximum benefit at the end of treatment and then kind of gradually falling off. Instead, with this approach to maintenance, you see continued improvement up to a year later. And patients really, really like it. So it's being used right now in a number of studies looking at patients on pain who are taking opioids and to see if that can be an interesting way to enhance maintenance. I'm surprised that this hasn't been picked up more on people interested, particularly in arthritis, because it is a chronic disease. But there's an interesting emerging literature in that area. Some of the early studies by Magdalena Naylor and more recently by Alicia Keefe that I'd recommend people take a look at.
And are you kind of suggesting, or is the evidence suggesting that this use of this voice technology would be superior to, say, just like automated text or emails? Is there something about the voice that's a little bit more engaging for people?
Yeah, I think it is more engaging. One is patients really do feel connected. They're making these ratings once a day. Most studies have actually used the therapists that work with them during the initial training. So when they get that personalized message, they feel connected to their therapist. Compliance also has been incredibly high with this approach. It's very interesting, very novel, and I encourage you to take a look at it. I think it's the kind of thing that could be integrated into many healthcare professionals' practices ultimately.
Yeah, it sounds clearly it could be integrated across, like you said, many different conditions.
I should also mention, I did this when I described it, it isn't just ratings. The menus that you can access when you make your ratings also include little brief clips of your therapist talking you through, say, for example, relaxation, or you could access a clip on meditation or problem solving. If somebody's, for example, having trouble going to sleep at night, they can access a relaxation tape that might be a couple of minutes in their therapist's own voice, and people find that, again, very, very supportive.
Great, thank you. Now then, Jos, we have had a question about whether there's any particular exercises that might help with stare negotiation. Now, I don't, off the top of my head, I'm not familiar with any trials that have used that as a particular outcome, but I'm wondering if you have come across that at all, maybe in terms of a functional task or something in any of the data that you've seen.
Do you want me to take that one, Jos? So the same as you, Lisee, I can't remember ability to go up and down stairs as being an outcome measure in any of the trials, but we know, and Alessio alluded to it earlier, that there's different types of exercise are effective. So it could be strengthening training, it could be aerobic training, it could be specific functional task training. So that there could be a functional task around stairs, but that would kind of still need to be tailored to individual patients. So in terms of the evidence, no, but there's kind of more general types of exercise that potentially could benefit that.
Yeah, and I think the main point is that Jos has pointed out with the mediator analysis that quadriceps strengthening is an important, albeit a small effect, but it does have an important effect. And so really, making sure to address that quad strength will certainly help improve stare negotiation, both going up and going down. And, you could perhaps parse it out to focus on concentric versus eccentric exercises. But bottom line is improving your quad strength should help that. So, okay. So, Dr. Keefe, back to you. I was interested in your very first question that you had in your issues, where you're positing whether exercise should be taught separately from pain coping or not. And you said that you're kind of more in the camp that they should be integrated, and I would say that's would be my kind of intention as well. I'm wondering if you might speak to some of the arguments that why they should be separated. What might be the benefits of separating them out?
Yeah, I speak from experience in a study where we wanted to keep the therapist blind to prior treatments. And so people in this particular study underwent the pain coping skills training first and then went into exercise. And they were asked not to discuss their pain coping with the therapist, the physical therapist training them, and vice versa. And it provided a really kind of strange situation, you know. And I think what you would ideally want, and I think the results were not as compelling as other studies where we have them fully integrated. You know, we know that learning is context dependent. So I think the most efficient approach is to actually integrate it into exercise. And it's also a wonderful way to overcome some of those thoughts and feelings that I talked about, because people have an immediate experience during exercise, supervised exercise, of applying a skill, seeing the potential benefits, or maybe some of the problems, and have an opportunity to problem solve with their therapist around that, and thereby get more confident in the use of these skills. So my hope would be ultimately that people doing different types of therapy, occupational therapy, physical therapy, doing nursing, counseling, and so on, when there are opportunities for people to be dealing with challenging situations, pain-related situations, to take those as teaching opportunities, to do little behavioral experiments in that supervised context. I think it can be incredibly helpful for people.
And is there anything in particular for when someone experiences a flare? And I know they can be particularly difficult to manage and discouraging for people. Is there any kind of particular strategies for flare management that you would suggest?
Yeah, so we've done some work on using the relapse prevention model, maintenance enhancement strategies, and so on. And one of the things that we have found very helpful that we introduce during treatment prior to the patient stopping and maybe having a flare and a setback and that sort of thing is actually developing a brief plan that they can use and that they can share with those around them, and even share with their healthcare team, that when I get a flare, these are the things that make sense for me to do. And that revolves, not surprisingly, around modification of activities, typically for a given period of time, a couple days, something like that. It may involve starting, say, an anti-inflammatory medication. It may involve increased use of some of the strategies to regulate emotion. So maybe if you stop using meditation or relaxation, deliberately increasing that for a few days. It almost always involves a communication plan of sharing with a significant other. Look, I'm on this plan for a few days now, and it might involve sharing that with a healthcare professional. And we found that people simply having these plans written down off to the side is very important for them, and makes them feel much more confident that when and if a flare occurs, they can manage it in a way. They have a way to deal with that. And we've also found that significant others find these very important and useful for that reason.
Yeah, I think that's excellent. I mean, I've done some brief action planning training myself, and I think it's incredibly useful and so approachable for the patients too, to be able to identify these kind of short-term goals that are, you know, feasible and manageable for them, and even better for them to be able to know they can rely on these things during a flare. So that's great. Okay, we'll turn back to maybe Jos now. I wanted to ask you about the mediators. There wasn't a whole lot that you found in the data, and just the one was kind of came through in terms of significance. I wonder if you have any thoughts on any other mediators that you know, might be worth investigating, that we just haven't seen in the literature yet.
Yeah, good question. It's I think one of the factors, and I actually addressed that with the hand osteoarthritis, I think that's actually for the knee osteoarthritis as well. the anti-inflammatory effect of exercise might be very important. And it hasn't been measured in many trials, and it wasn't available in the IPD that we received in this project. But in a previous project, I did a secondary analysis of the so-called ADAPT trial of Dr. Michier in North Carolina, who did a diet and exercise program in people with overweight and knee osteoarthritis. And there we actually showed that there was a significant reduction in some cytokines, and that this reduction in cytokines after the intervention was actually explaining 20 to 30% of the effect on pain and function, independent of a change of BMI, because we know obviously fat tissue also produces some inflammatory factors. So that was only one trial, and yeah, I was hoping to reproduce such data in our IPD analysis, but we didn't get any trials in measuring the inflammatory effects. But compared to the effects that we saw for muscle strength for these outcomes, the anti-inflammatory effect seems very promising, and there are some ideas how to optimize that, and I would be very curious what would be the effects on pain and function if we do a trial that actually focuses on these elements to optimize the anti-inflammatory effect. And that's for knee osteoarthritis. I would love to do the discussion that we had for hand osteoarthritis, but also hip or other joints. I don't think there's been much attention to these working mechanisms, which I think could be a way to increase the effectiveness of our study. So maybe also a call for others to start looking for them and measuring these potential mediators along these exercise trials.
Mm-hmm. Yeah, and as I said too, in looking at the mechanisms of EIH, to my knowledge, none of those mechanisms have necessarily been studied in osteoarthritis. So the whole kind of wealth of research questions there, kind of looking more at physiological aspects that maybe they're mediators to the pain and function, right? We have to kind of keep looking down the chain to be looking for these explanatory causal links. So
yeah, totally agree. We had only a few and only used the patient-reported outcomes of pain and function, which like we had with the stair climbing. There are other ways to measure the effects, and also like you showed that the measure of pain is very complex, and the patient-reported outcomes is only a part of that. So there's definitely more to do there.
So since you brought up PROS, I'm going to use that as a segue to a question that Jason has posed, and he's asking how often should pain PROS be collected in RCTs? And do you think sleep disturbance is something that should be included? And Frank, feel free to jump in on this.
Want me to go for this one?
Go ahead.
How often PROS should be measured? I think that probably really depends on the specific research question, depends on the specific question that you want to answer. But because osteoarthritis is a long-term condition, ideally it needs to be measured in the long term as well as the short term. And from the results and the trials that were included in STEER, the majority of trials focus more on short term. So there was much less data available on the long term at 12 months. But because it's a long-term condition, ideally it's great to collect the long-term data. But obviously that's got funding implications, so it's not always possible.
Dr. Keefe, have you heard, or in your trials, in terms of sleep disturbance, has this come up in terms of coping, something that people mention as being a difficulty, that their pain is disrupting their sleep and adds to their fatigue, etc.?
Yeah, I wonder if part of the driver for this question is the notion that, boy, if I monitor it too much, I'm going to bring too much attention to it and make the patient worse. They're going to start obsessing about their sleep or their pain. And this has been a question of interest to us because in a number of our studies, because of the research question we were asking, we were having daily diaries in which patients at least once a day, and sometimes more than that, were entering ratings of their pain and their sleep and mood and coping and so on. And a number of studies we looked at, is there reactivity? Are there patterns where things are, getting worse and so on? And we did not see that actually. And that's been reported in other studies where this type of daily monitoring is done. So I don't think there's necessarily a danger that simply recording these PRAs are going to make people worse. Many of you probably run into that with your institutional review boards. You know, don't ask about sleep because you're going to make the person worse. But in fact, these measures usually have been developed and used over time, and typically they do not cause, you know, adverse reactions. So I think that's an interesting question, and I would really defer to what Mel said. It really depends on the research question that you're asking. In our studies, we were very interested, because coping can vary from day to day, just like pain, is how some of the changes in coping that we were teaching could drive day-to-day improvements in pain and mood and sleep.
All right. Yeah. Oh, sorry. Go ahead. No, go ahead. No. Yeah.
I was just going to add to the point about sleep, and actually Jos and I were involved in a little kind of student project related to STEER, because we were interested to look at the effect of exercise on sleep as an outcome measure. So as part of this kind of linked student project, we tried to identify the trials that had measured sleep, and I think we could count them on one hand. Was it 5 or 6, something like that? Measures of sleep were variable, and we included one kind of proxy measure of sleep, which was night pain, because there was so kind of little, and I think that it was just really inconclusive. So you'd think that sleep would be really you know, well measured in trials, and you'd think that the exercise would be beneficial for sleep, but at the moment that the evidence just isn't there to support that, because it's just poorly measured in trials.
Yeah. And we've had a comment in the chat from Ali Mobasheri, and who's suggesting that maybe we don't use questionnaires to measure sleep, but you try to measure it more objectively, you know, probably in a lab setting with the technology to monitor them. And I would imagine, and I'm certainly not, you know, an expert in this area, but I would imagine there might be differences, just like we see with physical performance tests and self-reported function, that we would see discrepancies in what we measure in the lab but regarding sleep quality versus a self-reported questionnaire. So again, that would be an area to expand on. Following up on the inflammation piece, Jos, we had a question about, so you mentioned that there was anti-inflammatory effects of exercise on systemic inflammation. Wondering if you're aware of joint-specific anti-inflammatory effects of exercise.
No, the most studies that measure inflammation after exercise do it by taking a blood sample. So these are more the systemic measures. Of course, we can measure inflammation in the joint by something like MRI or ultrasound, but I'm not aware of studies that did long-term assessments of the inflammation. The review on the safety showed that there was no effect of inflammation. I'm not sure whether that was separated for systemic or local, but I'm not aware of any studies that did assessment of local inflammation over a longer period of time. We know that a single exercise boot would not increase inflammation that much, but it's, I think, like Mel said, for such a chronic condition, you want long-term effects, and I'm not aware of those studies on the local inflammatory status.
Mm-hmm. Yeah, I think that's still something that needs to be developed as well. Okay, going back to your IPD study, I'm wondering if you have seen anything to indicate that there might be differences in responses based on different subgroups that you're seeing in your data. Have you had a chance to look at that at all?
Do you want me to take that, Jos? So the subgroups that we measured, we chose those. It was really interesting. So we had a lot of collaborators, I just saw from the last slide, who were involved, and we had some really interesting discussions of what are potential moderators of the effect of exercise. So we put that question to the collaborators to start with, and I think that there was 47 different possible moderators that were suggested, and we also asked people to rate not only what was important but also which direction of effect they thought that the moderator would have. So, you know, for example, whether somebody who had greater muscle strength would do better than somebody who had less muscle strength, and even the kind of knowledge or beliefs about that kind of direction of effect was just really varied. And I think it reflects the literature that at the moment it's, you know, it's really unknown. So we had to kind of shortlist the moderators in some way, and so we just went for this kind of ranking. But what was also interesting is that when we looked at the top rated moderators, and I think that number one on the list was it motivation to exercise? But again, it just comes back to what's measured consistently and routinely in trials. And so some of the moderators that the researchers and the collaborators, so patients as well, were involved in that decision making. So some of the moderators that were voted as most important weren't actually measured in the trials, and so then we couldn't explore them. And I think again, it just comes back to this idea of what are the kind of core measures that we want to include in these trials going forward.
Mm-hmm.
I'd just like to make a comment on your study of mediators and moderators. You know, I've been at this a long time, as you can tell from the gray hair, although I'm not complaining I have hair. So I'm pleased with that. But I think I've looked at every potential mediator and moderator of the treatments that we've developed over time. And what is so discouraging is the lack of consistency. You know, I've looked at the research that others have had. You know, there'll be a study, and I'm guilty of this, you know, published, oh, we found age or we found this. And just the fact that it doesn't hold up. And what I really like about your work is that you're asking for these data sets, you're getting larger data sets, you're obviously interested in finding things that are potentially replicable. And I think it's a very, very important effort. You certainly probably found, if you've ever done an outcome study, one of the first questions from the audience is who's going to do well or do poorly with this. So I think it's a very important question. And I think the way you're approaching it is much more methodologically sophisticated than many people. And I sure hope you'll find some consistent, reliable moderators and mediators. If I had to put my money on anything, I would put it on mediators, because I think the most consistent thing I've seen in my literature is not a moderator, it's a mediator, and it's changes in self-efficacy over the course of the initial training period as a mediator of short and long-term improvements. Those are, you know, not necessarily exercise studies, but it seems to be the things that happen during treatment, maybe the targets of treatment, seem in the studies I look at more reliably a mediator, but not, you know, not so much that I, you know, bet my house on it. But I like the way you're approaching it.
Thank you. And just to add to that, we're collecting this as a resource, and it's everybody's been fantastic, and it's a collaborative effort, and everybody shared the data. And the great thing about the OA trial bank is that that's now that it's got the data, it's stored the data, and other people can access the data. So if you're interested in running any analyses, and that's a really great suggestion, but people can access the data. You've just got to go to the OA trial bank and put a request in. So that data is there now for use in the wider community.
And if I can make one additional comment on that, maybe because this initiative was set up to find moderators, of course, and find mediators, and we might have gone over it too briefly, but the fact that we don't show a moderating effect for something like age or comorbidities or those factors can actually also be explained or interpreted as there is an effect for everyone, young age, older age, with and without comorbidities, low body weight, high body weight. So somehow we're looking for subgroups to enhance the effectiveness, but on the other hand, we also took away maybe some indications for lower effects in some of these subgroups as well. So there's definitely some important messages in not finding any moderators.
Great, and we've just got a couple minutes left, and I thought, Dr. Keefe, I'd ask you, just because we touched on self-efficacy and the importance of it, but yet I believe it was on the moderator list, and it wasn't significant. I'm just thinking of your mindfulness, your intervention, and just thoughts around the relationship of that to improving self-efficacy.
Yeah, we're actually involved in a study now looking at, are there specific mediators of specific treatments? So does mindfulness specifically explain the outcome of mindfulness-based treatments? self-efficacy, behavioral treatments, and so on and so forth. And, you know, we have collected those measures and looked at them as potentially important mediators. We are not finding evidence that it's specific, that there's anything specific, a specific mediator going with a specific treatment. Again, self-efficacy emerges. Even though mindfulness is not necessarily focused on improving self-efficacy or other acceptance-based approaches, I know that advocate, you know, sort of being willing to experience the pain and don't control it and so on, also seem to be mediated by changes in self-efficacy. Again, it's not necessarily this literature that we're talking about today, but I think it's a key question. Do these treatments, whether they're exercise or other approaches, do they work through similar mechanisms? You know, maybe some of them are the biological ones that you mentioned, Lisa, or are there theoretically specific ones that we ought to be looking at more closely? But again, I would just, the experience of one person having tried to do this many, many years with personality. I mean, any psychological measure you can think of, we tried to look at with large data sets that, you know, over the 30 years. They just don't hold up consistently, and I sure hope we can find some.
Great. Well, on that note, I'm going to pass things back over to Jason. I'd like to thank all of the presenters for your contribution and your time today. It's been wonderful. And I hope all the participants have enjoyed the information that's been shared. And I myself would like to thank the Arthritis Foundation for this opportunity.